So previously we've looked at injection and infusion drugs for the treatment of MS. Now we're going to look at some of the commonly available oral agents. So fumarates may have a neuroprotective and immunomodulatory role. The exact mechanism of action, however, is poorly understood. It's thought to block cytokine induction, and there may be some role in terms of antioxidant properties. We don't know. The most common side effects are flushing and GI upset, including diarrhea, nausea, and abdominal pain. Taking the medication with food usually decreases the rate of GI upset. Teriflunomide affects cells that are rapidly dividing, such as T cells, due to its ability to inhibit pyrimidine synthesis. This is one of those anti-metabolite drugs. It also disrupts the interaction of T cells with the antigen-presenting cells, as well as reduces cytokine production through the activation of the NF-kappa B pathway. The most common side effects of teriflunomide are diarrhea, nausea, hair thinning, and elevated alanine aminotransferase levels. The last drug on this list is Gilenya, which is the trade name. Fingolimod is the generic name. And this is an S1P, or sphingosine receptor 1 partial agonist. And what it does is it sequesters immune cells to secondary lymphoid tissues, basically trapping them so that they can't have their effector function. Typically, this drug is well tolerated. It does produce leukopenia, of course, which is the required or the intended clinical outcome. There is a first dose bradycardia that is well documented in the literature. It doesn't seem to be problematic, excuse me, and it seems to correct itself within 24 to 48 hours. But as a rule, this drug does need monitoring because it is immunosuppressive in nature. Other symptomatic treatments that you can encounter in the literature include methylprednisone, which is commonly given for acute attacks or flare-ups of MS. If the patient is not responsive to steroids, IV immunoglobulin pheresis may work. Delphamphridine may also be used to treat severe motor deficits in new onset patients or even in established patients. This drug's been used for quite some time as well. In the MS, loss of myelin causes all or none action potential to decay into a graded potential. If this graded action potential is insufficient to cover the gap caused by demyelination, conduction block will result. Delphamphridine works by blocking open potassium channels, which can increase the length constant and in many circumstances overcome this established conduction block in this disease process. This will lead to an improvement of walking. Higher doses of delphamphridine have also been associated, however, with seizures. I like this summary diagram because what it does is it kind of puts into perspective this risk-benefit ratio. A lot of these drugs are, in and of themselves, quite horrible in terms of their side effects. Many of them are cancer chemotherapeutic drugs or immunosuppressive type drugs, which we'll learn about in great detail next year. But we've actually talked a lot about immunosuppression as a pharmacologic tool. And a lot of these drugs are no different. And what this diagram basically summarizes is that the drug efficacy goes up, but so does the drug risk because these drugs are becoming more and more potent. What's difficult to grasp is that the patient's disease process is also advancing, and so you need stronger drugs to basically treat these patients. And so there's multiple factors that kind of filter into which drug is better. You notice that we didn't really spend a lot of time talking about that, and that's for two reasons. One, from the step one perspective, they really just kind of want you to be familiar with these drugs and have more of a bird's eye view of mechanistically how they work. Treatment of MS and the management of patients with MS is obviously a subspecialty, and there's a specific residency and a specific fellowship that you would do in order to treat those patients. And so this isn't really family medicine or internal medicine, but you should be acquainted with the main drugs. This is kind of probably a much more broader topic. From a step one perspective, they typically just tend to focus on some of the drugs that I mentioned and their unique side effects, which is pretty standard for more complicated diseases. Cancer, immunosuppression, graft versus host disease, MS, lupus. Some of these multifactorial diseases or diseases of unknown etiologies are quite difficult to treat, and they just kind of want you to have kind of a cursory view of the current treatment options that exist for these patients. Likewise, I've included this notion or a little bit of brief description of escalation therapy, and all that really translates to is second-line therapy. And so the first-line agents are more or less listed here. The second-line agents you can see are a little bit more potent, have a longer side effect profile, and then as the patients progress, they typically go on experimental treatment protocols, which may include several of these drugs in combination, or what's called in regimens. So it's like 3 weeks of this drug followed by 1 week of this drug, 3 weeks of that drug followed by another week of that other drug. And so it's very similar to the chemotherapeutic regimens we're going to talk about next year. For patients that are initially treated with interferon beta drugs or glatiramer that show inadequate responses, the physician can switch to an oral agent such as fumarate or fingolimod, or they can even give them IV natalizumab. For patients that are initially treated with natalizumab who have an inadequate response, typically stop taking natalizumab and start taking one of the following oral agents. Okay, and so basically what you're doing is you're just kind of following this treatment paradigm, and you're trying to find the best drug that's the most potent for that patient. And so this is kind of just an overall view of how complicated this literature can get, and hopefully we've just kind of shed some light on some of the major drug classes that are used for these patients. Okay, so if you have any questions, please email me, and enjoy the rest of the block.